Good morning, everyone. Welcome back to Treat Live. This is the fifth installment of our live case series here at Mount Sinai in New York. It's my pleasure to welcome everybody. In addition to myself, I'm joined here by Tino Pena down at Miami, Miami Baptist. Welcome, Tino. Good to see you.
Hi,
Uh,
good to
he's
see
gonna
you, Evan.
he's gonna help moderate this live case today. We have a very interesting case here. Dr. Lookstein and Dr. Patel are working on in room one. I'd like to first thank BroadMed AV for again supporting our live streams and having it be such high quality. So with that, I'm going to hand it over to Rob and Rahul, and they're going to introduce this really interesting case for everybody.
Aaron, can you hear me?
Absolutely.
Okay, fabulous. So I want to welcome everyone to room one here at Mount Sinai Hospital. As Aaron stated, we're at the fifth installment of Treat Live, and I'm really proud of the entire team that's put this together. Again, I want to thank BroadMed AV because without them, we wouldn't be able to put on this great educational content. I'm joined in the room by a phenomenal team. We've got amazing technologists, amazing nurses. Our entire team here at Mount Sinai are really best in class. I would argue best in the U.S. right now. No offense, Tino, but we couldn't put this on without just the fantastic techs and nurses, and in this particular case, our great anesthesia colleagues. I'm joined in the room by my a close partner, Rahul Patel, who's working to my right, and then we have one of our superstar PGY6 IRDR residents, Toyin Dada. We've prepared a very brief presentation here to go over the case that we're working on, which I hope everyone finds very educational. It's a really fascinating case. And Dr. Dada, if you'd be so kind to go over the case presentation.
Sure. Can everyone hear me okay?
Loud and clear.
Awesome. So today we have a 72-year-old female. She has a history of refractory hypertension, asthma, H. pylori gastritis treated in the past, CAD, prior stroke, hypertriglyceridemia, and prediabetes, and she had presented with postprandial pain and sensation of food getting stuck after she had a cholecystectomy in 2023. Between that time period, she'd lost 30 pounds in the last year due to inability to tolerate solids. She had an EGD done after that, which showed a hiatal hernia, some gastric erosions, and Barrett esophagus. She had an MRCP following that, which showed pancreatic cyst and stenosis of the celiac artery and SMA. So after that, she underwent unintended revascularization at an outside hospital, but it was aborted because they were unable to cross the occluded visceral vessels. Next slide. So here we have her past surgical history. She has an allergy to iodine, for which we pre-medicated her for today. She's on medications such as rosuvastatin, aspirin. She's on 3 blood pressure agents, as listed here, some asthma medications, and omeprazole. Her vitals at the time you saw her was 150/69, and that was on 3 antihypertension agents, and the rest were within normal limits. At the time of exam, her chest exam was normal, abdomen was soft and non-tender, there was no rebound or guarding. And then obviously we checked her left radial pulse to be able to see if we could do the procedure for today. Next slide. So we're going to run, this is a quick run through of the pre-procedural CTAP that we got. And just quickly, the celiac axis is included, so is the SMA. And then we noted that her common hepatic artery comes off of that. Her IMA is also has high-grade stenosis, and she has right renal stenosis as well. And then I have some stills on the next slide for you so you can see it a little bit better. To the left of the screen, that is her SMA, or celiac artery rather, is just totally included, with the SMA in the middle, which is also totally occluded. And then on the right, we can see that her common hepatic comes off of that occluded SMA. And then we can go to the next slide. Then on the left of the screen, we have her right renal artery, which shows high-grade stenosis, and then her inferior mesenteric artery, which also has high-grade stenosis. All right, and that's pretty much it for our presentation. And that brings us to
next slide, please. So I think there's,
yeah, there's one more. So she's a 72-year female with past medical history of hypertension, H. pylori gastritis, CAD, stroke, hypertriglyceridemia, prediabetes. She presented with persistent postprandial pain with concern for chronic mesenteric ischemia and right renal artery stenosis. And just to recap, complete total occlusion of the celiac artery, SMA, with replaced common hepatic artery, severe stenosis of the IMA and the right renal artery. And we discussed this treatment plan with the patient, and the plan was to revascularize the SMA via the transradial approach.
So thank you, Toyin. So, a lot of interesting things going on with this case. And I'm going to go back. Rahul's working feverishly, thank God. But if we could go back to the first angiogram, please, just to show you what we're doing.
Sorry.
So this is a lateral. Actually, go back to the previous angiogram, please. And Aaron and Rahul, can you guys see the
yes.
angiography, the DSAs? Okay. So you obviously see here that there's diffuse athero of the infrarenal aorta. Keep on cycling it. Essentially, shelf-like calcification of the aorta. You see this critical narrowing of the right renal artery. You don't see any antegrade filling of the celiac and mesenteric access. I don't think it was, so clearly delineated on the CAT scan, but there's a critical stenosis of the IMA also. You see a hypertrophied marginal artery, a hypertrophied arc of Riolan, and then a distal reconstitution of the SMA. What's very interesting in this case, which hopefully will lead to some, fascinating conversations in just a moment, is that really not only the entire midgut is coming off of this SMA trunk, but also the foregut, in that the common hepatic artery, when you really map out the CT scan, is coming off the SMA. So she really needs this SMA done for her to get, I think, really durable symptomatic relief, and which is why we've been sort of feverishly working on this so far. Next angiogram, please. This is a oblique angiogram, and just to back up a little bit, we placed a 5/6 slender sheath in the patient's left radial artery, and the previous diagnostic angiogram was performed through a 5 French Serra radial catheter. This is now a 6 French 100 centimeter runway guide cath in an MP1 configuration from Boston Scientific. We've advanced it down to the, again, the visceral aorta, and we're trying to find something that appears to be like a nub to get into this large SMA trunk. Next angiogram, please. Here we're sort of floating down, and you can see that right renal artery, and I think if this case goes relatively quickly, we'll probably end up treating the right renal artery today also, but obviously we're here very focused, laser focused, if you will, on the superior mesenteric artery. Next angiogram, please. And again, we're just trying to get our systems in place here. We're starting to see some semblance that there's a little bit of a nub probably there in the center of the screen. Next angiogram, please. And again, we're just getting closer. Next. And sorry, if you go back a little bit. Yeah, there. So here we have a guide, and Tino, I'm really looking for you for a little bit of guidance here, but we have two 018 hydrophilic wires in tandem that we're using in like a stepwise approach to try and get traction. So one will maybe, bite a little bit on this CTO. We'll escalate the guide maybe by 3 or 4 millimeters, try a second wire, and then you should sort of use them in tandem. It's one of the benefits of working through a guide catheter like this. But Tino, I know that you and your group do renal artery occlusions and visceral artery occlusions. What's your setup for something like this?
Yeah, I think this is a great way to think about, how to maximize your pushing power. A lot of people still, when they're talking about other type of approaches, want to make sure that they continue to have the ability to have a good amount of push. And I think having the 2 wires and be able to escalate is a great technique, the way you just showed it there, and be able to get across. So I think that you really kind of showed a good idea and a good way of doing that. And now you have a better chance of maybe advancing even a little bit further because you have the 2 wires. So I think it gives you the benefit that you can
So
step.
So in full transparency, as usually happens, I'll try for 5 or 10 minutes, which I did off camera, and then Rahul will come in and be able to cross in about 3 minutes. And so while we were checking, Rahul was able to cross. And so you can see here that we're through the CTO. And we actually have both wires through the CTO. And so that was, again, working in tandem, a V18 and a command 18. And here's the AP view. So again, I'm just going to throw it out there. Aaron, Tina, what would you do at this point? We've got a CTO. We've got a decent working wire across, which is an 018 wire of note. I don't think we need that necessarily. I think we'd probably we could take one of them out. But I'm just curious what you would do.
So Rob,
No,
is your plan to work over one of these wires, or do you want to try something, or are you thinking of switching out to a different wire potentially to work over?
Well, I'm open to anything, but I figured I would open it up, and I think that none of the sort of options right now this second are really ideal. We got to think long and hard about what we're doing.
Is that really on? Is that the right?
And
well, in
I
terms
think you
of
just
the
saw
diameter,
this angiogram.
In terms of the diameter of the wire, right? I think you mentioned that both of these are 018 wires, right? And
Yes.
I think at this point we probably want to think about, let's work backwards and think about what we want to ultimately place stent-wise into this vessel. We should probably talk about the different options and what's available currently on the market, and then work backward and decide what wire to place.
One of these branches down here.
What do you think, Tino?
I think that's the way to think, right? Are you thinking here of a covered stent or a non-covered stent? Are we using some of our traditional stents? I've had trouble putting our traditional stents through that runway. So you may have to go to something, lower profile, but that's just been my experience. And then what do you want to do to once you decide what you want to do, how are you going to prep the lesion? Do you think you need to prep this, or you want to go primary stent?
It's open. It's open on the table underneath the.
I think we're going to need to prep it. That's my 2 cents. And we're all set up to do IVUS also if we think that's going to be helpful. But we're thinking we're going to probably pre-dilate it right now. I'm curious as to what you guys think about pre-dilatation, what you would do.
So I like the idea of pre-dilatation, Rob, for a couple reasons. Number one, I think this is a really rocky shelf and it's going to be hard to get anything to pass through. So I'm curious to know what balloon you're starting with. And then number two, we could potentially, once we have a bigger channel, we could send down an 014 wire potentially and then put down, a number of different stents that I think we have in the lab.
So again, what size would you pre-dilate if we're thinking that's a good idea right now?
I would say maybe 2 millimeters, something like that, maybe 3.
Tina, what do you think?
Yeah, I didn't get a good feel from the CT. I mean, the CTA looked pretty bad, and it looks as though you're fighting there. So I think it's pretty tight. I think there's 2 questions: what balloon is actually going to go through that, follow that wire, and then what you need ultimately. And a lot of times, what you want to do is sometimes you need to get your first balloon just to create a little channel and then step up. Sometimes we try to do it all with one pre-dilatation. You may need to prep with a series of balloons. On these situations, we've actually tried a couple of times now. I think it's an off-label use of the coronary shock wave when it's really calcified. And again,
that's
it's
a great idea.
Experience.
Yeah.
Anecdotal experience, but it does go well over the wire on that 014.
Okay, so are you guys able to see our live feed right now?
Yeah, we see that.
Good.
What size is that?
So
Rob?
that was a 30 by 20 millimeter 018 Sterling balloon, which tracked perfectly.
A little further.
Okay, and we're going to send it out just a hair further, just to make sure that we have enough room to work here. Okay, and again. It's working well over this 018 wire.
Should we get the origin again?
And then we're just going to probably hit the origin on the way back just to make sure we've got some working space. And then we're going to see if we can float down a workhorse 014 wire to Aaron's recommendations just to try and get something a little bit more stable down here. So again, it's nice to have a whole inventory of balloons here ready to go. And we're going to,
Rob,
again, get this balloon out of here.
You mentioned this is a Sterling wire. There's different, just for the audience.
Sterling
balloon.
angioplasty balloon. Yeah.
There's different types of balloons for these types of applications, and so I know that we have a rapid exchange platform and an over-the-wire platform. Do you or Rahul want to talk about? I think you guys are using a rapid exchange, although I can't tell exactly.
That's absolutely correct. Our default for all of these cases is to work over rapid exchange platform, especially if we're working radial. We feel it makes the ergonomics and the workflow much more efficient. Most of both Rahul and I, were more or less, very well trained in a multidisciplinary format with both radiologists and cardiologists. We've largely migrated over completely to rapid exchange platforms. And so we feel that that's a very, very good platform to work over for this.
Tino trained me well.
Yeah. No, I think that Sterling balloon is a great choice. I think it tracks really well. I think at 018 and rapid exchange, you saw how well it went down there and was able to get, read the profile really well. When do you start thinking about where do you want to start and end with your stent, and when do you start considering how far do you want to cover into the SMA?
Well, I'm hoping we can talk about that in just a minute. Okay. So I'm just
think we probably need better
imaging
to
map
sort of
this
figure
out.
that out. Yeah.
All right.
There we go.
Still not quite where I want the wire, but I guess it's fine.
So that, one of the things that I was thinking about, Tina, when we were talking about the different types of balloons, rapid versus over the wire, a lot of people still approach this case from a femoral approach, and I think one of the things that we lose a little bit with rapid exchange is that pushability. Even though this is a really good platform, sometimes there's issues with pushability, and I think if you were approaching this potentially from the femoral artery, that might be a concern. Whereas I think with the radial approach, and then obviously years ago we used to do this from a brachial approach, limits some of the ability to get a rapid exchange across these lesions. What do you think about that?
Yeah, I agree with you. And I think, we can't underestimate the power of that guide cath that you have right there. I think that's really giving you great support. So even though you feel like, hey, I'm farther away than I would from a femoral approach, your angles are beneficial and your support is almost in line. And I think that's really the point you're trying to make. Yeah, I think you definitely see that you get that wire to go, plus you have that pushability. It's almost a straight shot.
I wrote the guide down, right?
Yeah.
Down.
And I think these rapid exchange systems now are so, they just really slide in pretty easy. And I think that's also a huge benefit.
Yeah, they're very low profile.
So now we've got a coronary wire down. You can see we've got an 014 wire down in the iliocolic branch in the right lower quadrant there. And again, Tino, to your conversation, it's pretty nasty, SMA CTO here. So the question is, what do we want to do?
So let's just start with basic stuff. Anticoagulation. I'm assuming you're fully anticoagulated. And I know you very well. I know the patient was on aspirin.
Exactly.
Yeah, so she's got about 5,000 of heparin total, and she's
Right. So we have full therapeutic anticoagulation on board, and I think the question is, do we continue to vessel prep? What's the implant we're going to put in? We haven't even gotten into whether we're going to think about reconstructing the hepatic or not, or whether we're just going to focus on the SMA. These are all really good questions to start thinking about right now.
Well, why don't we talk first about the hepatic? How is her liver getting perfused right now, Rob? Do we have any pictures of that?
Well, obviously it's a CTO, so it's predominantly getting perfusion through a very hypoperfused hepatic artery. Where the pulse pressure is probably on the order of 40/20 going through a CTO, and then predominantly the portal vein. So that's just one theoretical question of whether or not it's even worthwhile to reconstruct the hepatic, or whether we should just really focus on the SMA, since we're treating her for chronic mesenteric ischemia and she has no signs of hepatic dysfunction in the setting of this hepatic artery filling through collaterals. So I'm gonna pause for just a second. Tino, I want to ask you. We're going through a SMA CTO in a we didn't go into this so much, but a very, very petite woman, and we are working very, very diligently. You could see the vessel prep was nice but not ideal. What do you think for implants here?
So I think for implants here, I still like the non-covered balloon expandable stent here. I think it gives me a lot of different opportunity and a lot of different options. I think a covered stent, I think you can't argue with that, but I usually keep that as kind of in my back pocket if I really think I need it, if I think I'm going to really have more of a complication. I think our rates of patency have been pretty high just with balloon expandable. So I usually go with that. If I go with a small stent, which I try to avoid, then I start thinking about a drug-eluting stent or a coronary stent. But usually I can get into something a little bit bigger.
So, Tino, I'm so glad I asked you that question, because we're literally right about to put in a coronary drug-eluting stent. This is a 5mm Megatron stent. Obviously, this is an off-label use, but this is a 5x20, and I suspect we're probably going to need to have 2 telescoping stents here. We've actually been using this implant fairly regularly for renal arteries and for visceral artery CTOs. We find it's been working very, very well. And we think that that's probably a very safe way to go here. Obviously, it tracked very nicely through this 6 French guide.
Well, that's the other thing about that product, right, Rob? Is it's very, very, very trackable. Probably better than some of the non-coronary ones that we've used.
I love the choice.
So we're just mapping it out. We're just mapping out how distal we want to go. We want to get a lot of different obliques to make sure we're not fully covering visceral branches.
This brings up a really good point,
so far,
Rob.
I
right?
like this.
Yeah, maybe a little bit further in. What do you think? A few millimeters in?
All right, Tina, what do you think?
Yeah, I thought so. On the other view, I was still worried about that little branch. So a little bit further in, I think I like. But I love this stent. I think it's the best of both worlds. 5mm, but still still getting the coronary advantage of the drug elution. I think that's great.
You're going to need 2 anyway. So really what I'm looking at when I place these is the distal location first, and then you're going to have overlap for the proximal stent that you're going to place, I think, second. So really what I'm looking at is that distal marker.
What'd you guys think of that run?
I think that looks pretty good, Rob.
What'd you guys think of that run?
I think it looks good.
Okay, Tina, what do you think?
Good. I do too. I think you're past that. You're before that branch.
All right, we are going to go. Now this balloon at burst pressure goes up to 5.4, and that's 16 atmospheres. 12. You can also dilate it basically up to 20 atmospheres, and that's a 5.6, which is probably a good. I would say we should go up to 16. To see how that looks. We can always post dilate later on, but so 16 is essentially a 5.4mm balloon expandable stent, and we're going to need the second stent soon. Let's manually take this down.
So Rob, what was the diameter of this vessel when we measured it on the CT?
It was just over 6.
Okay. So this is going to probably be around 5.5 or 5.4-ish, right after that indication?
Yeah, 5.4. Yeah.
And then what I think we could do if we're very efficient with our time is we could IVUS this afterwards just to make sure that we have good wall apposition with the stent, and see how that goes.
I think with the amount of calcium that you have in there, I think this size is going to be great. And remember, what you're trying to do is just really increase some antegrade flow, and she's going to do just fine.
Yeah. So it looks like the next stent's going to be a little bit shorter. Are you going to try to use something similar and just overlap it?
I think we're going to use something similar and overlap it, and we're going to go back to that same oblique where we're able to see almost like a true lateral. So there we are, and you can see we got to go right up to that big shelf of calcium that's right there. So I think the 20 is going to be the right size. That last stent was a 20. This new stent's going to be a 20. If I had to guess, our total coverage is probably going to be just under 4 centimeters.
Yeah.
So, just I guess point of contention, right? So you're doing 2 drug-eluting stents with a lot of overlap, theoretically. Concern about too much drug or?
Again, that's a theoretical concern. I personally have not heard that that's a concern with these polymer-based stents. The nice thing about the Megatron is it's a abluminal-based bioabsorbable polymer. So the polymer coating's relatively low. The duration of the polymer is relatively brief. So that's what we're looking like. What do you guys think?
I think I would pull the guide back and take another quick look.
Yeah.
But that's a great technique, Rob.
That's exactly what I did.
I think what you're demonstrating here is using and this is what Tina was mentioning before, using the guide to sort of give yourself pushability into that calcified lesion. And then once the stent's in position, pulling the guide back and taking a picture.
That's actually pretty good.
That looks pretty
So what do you guys think so far? In like 2 more millimeters, something like that?
Right.
We can go a little bit more oblique. I can get you.
Right.
It looks like you got a millimeter,
a little bit more.
Looks like a millimeter or 2 in the aorta, right? It looks like that.
Yep. I like that.
That
what
looks
do you guys
really
think?
good. I think it looks great.
It looks great. I think you could always go a little bit more in the aorta if you want, but I think it looks perfect. I like the overlap there.
I'll probably do a little more, like a stent cell in the aorta, right? Then we can go.
Yeah, we're going to go here.
Maybe one, yeah. That's probably a little bit better.
I'm going to put a little bit of forward tension on it.
Oh, no, that's too much. Now you popped in, right?
Okay, so now like that, right?
Yeah.
Okay, let's go.
Ready?
Yep.
The other nice thing about this stent, and we probably should talk about that, is you're going to consider maybe plus or minus IVUS whether you're going to go back in maybe with a 6 millimeter balloon and post dilate it, and this stent can go up. I believe this can go up to 6 without an issue, right, Rob?
That is correct. You can take it up to 6.0 without disrupting the polymer at all, which is a very, very nice, property of it. People have anecdotally told me you can go slightly above that. I wouldn't recommend it, obviously, but I think for the purposes of this patient, we're trying to, get it to 6.0 maximally, and hopefully allow her to get some relief from her mesenteric symptoms.
I got the guide.
Do you want to talk a little bit about our antiplatelet protocol with these stents and whether it's different than if we're using a bare metal?
I think it's, obviously drug-eluting stents in the visceral circulation is off-label. We all have anecdotal experience. This patient has significant athero, obviously. I think dual antiplatelet therapy here is completely reasonable as long as she can tolerate it. And then we need to make a decision about how long it's going to be.
Do a run.
And, take it stepwise from there.
Oof.
Now you see that interesting little waist there on the,
So that's yeah, that's pretty nasty.
Like a 6 sterling.
Yeah.
I like Rahul's idea. Put a 6 in. I think as we were just talking about, taking a 6 balloon, it's not going to disrupt the polymer, and you're probably going to be able to get a little bit better wall apposition with that calcium.
So you talked about abdominal.
Sorry, go ahead, Tino. I didn't mean to interrupt.
Abdominal, the polymer. I think that's something that people should understand. That the polymer is only on the vessels, basically on one side of the stent.
Right.
Can we get the
So what's nice here is obviously we've opened up the superior mesenteric artery. We have not covered any of the visceral branches. And I think you see off this angiogram, there's a very nice inferior pancreaticoduodenal artery coming off just distal to the stent. And as you watch the angiogram, it's actually very nicely reconstructing the gastroduodenal artery. And a little bit later on in the run, you're seeing the hepatic artery fill antegrade, okay? And obviously you get a sense of how proximal that common hepatic artery is coming off of the SMA, and obviously there's a CTO for that artery as well. We were Rahul and I were talking before we started the case about whether or not we could go after that common hepatic artery occlusion. I think just as an idea, wiring through all that to try and get the hepatic artery antegrade is probably not going to really benefit this patient right now. And so I hope you all agree. I don't think we're going to try that today.
I agree,
No,
definitely.
I agree.
Take the win.
Yeah, I mean, look, she was fine without any antegrade flow, and now you have some. So I think her liver is going to be totally fine. There's no reason to do that.
Exactly. All right. So as I promised, we're going to use intravascular ultrasound here, and we'll show you what the artery looks like. And this is a 014 volcano wire, the PV014. And one of the nice things about having a Philips platform, and in full transparency, we have both Philips and Siemens equipment at Mount Sinai, but room 1 is a Philips flex arm room, and it's a fantastic room for this kind of complex visceral work. But we have integrated intravascular ultrasound, and it just makes it very, very, very user-friendly. And we obviously think IVUS is incredibly valuable, especially when we're talking about putting in drug-eluting stents and other complex implants. Vessel sizing becomes, critical.
Well, also not to mention the dose in this room is as low as you can probably get at this point with the current technology. And a lot of these cases where we're going in lateral to do SMA work, the dose can get pretty high, particularly in larger patients. Luckily, she's not a large patient, but as you know, this could be a very, very high radiation dose case if you have older equipment.
I'm gonna show it backwards.
And that looks pretty good.
Okay.
Yeah.
All right. So this is the distal vessel, and again, you can see there's almost like an inflammatory process. The athero is so dense here distally. You all can see the IVUS clearly, right?
Yeah,
that's a great example of that.
So
yeah. And you're outside the stent here. It almost looks like you're in a stent.
Yes, we're outside the stent. So can we pause this and measure this diameter here?
I should be able to do it here.
Because I think that this will be helpful. And I would ask for outer wall to outer wall. Can we do outer wall to outer wall? That's inner wall to inner wall.
So that's
that
4.
measured about 4. So 5.5 for the inner lumen. Let's do right at the dark gray.
Further in. Nope. No.
Nope.
Right
there. Perfect. Yep.
There.
Yep. Exactly. What is that?
6.
That's about a 6 right there. Okay. Now, again, we've taken it to 5.4, right? And so I'm going to pull back a little bit now until we get to the stent edge. Again, you can just see this diffuse process. And this is right at the stent edge. Again, you see the diffuse athero there.
This is a great example of what you're describing here. Right? I mean, this is the kind of stuff that I think the DES is probably really helpful for potentially.
Oh, there's no question. So, Aaron and Tino, we have clearly wall apposition into the athero, but should we deliver the stent a little bit more aggressively? And then I think if the fluoro image is showing also, I'm pulling back into that waist that we have on the stent, which I think is going to be right about here. Yeah, see that waist on the stent right there?
So I think the answer is going to be yes, Rob. And the reason I say that is because you want to sort of push the stent up against that inflammatory process, but also I think you have that waist at the top. The only downside in my mind would be maybe a concern about vessel rupture up top. What do you think, Tino?
Yeah, I think that's the exact discussion, right? Are you going to take this is pretty much a winning hand. I don't like the compression of that osteal plaque. I think we can touch that up with a 6. I wouldn't probably go too far into. I definitely don't want to extend beyond the stent.
Yeah.
I would probably not go too far into.
You can far out. Stop recording.
I think it should tolerate a 6, and then I would get out.
Let's talk for a second about bailout, Rob.
Can we have a 620 balloon?
If you
So yeah,
do
so
have a
if
if you
if
do
we
have
were
a vessel rupture here, let's talk about how you would manage it.
so luckily the new VBXs, the 6 will go through a 6 French sheath. So we could theoretically put an R2P sheath down, right? A 6 French R2P sheath down, and then deliver a 6 VBX down. We'd have to go very fast.
To have a
Obviously, 'cause we have to
620.
switch
Oh, we
out.
have a 620 Sterling. Fabulous.
We
Yeah,
have to
and
swap
you'd
out
also have an
everything,
014
right?
wire. So yeah, that's going to be a tough,
Yeah. So we
thing to
could
do.
do that because we have the guide. We could just swallow the guide.
Push the guide
push the guide
across.
down, switch it out. Yeah, put a
Yep.
Rosen down, and then just deliver an R2P sheath, which we have, and we have the VBXs.
Okay.
So,
But that's a really good teaching point. I think, one of the things that we're always talking about with our trainees is what's the worst possible scenario, and are you prepared to manage it? What do you think, Tino? Is that how you would
I think
approach a rupture?
that's exactly how I would approach a rupture here. I think the 6 French VBX has kind of been a game changer for that. And I think you're ready to go. You're exactly right. Have the 6 French sheath in the room, and you have a plan.
as far
I
as
think that's the
in terms of
key.
mag.
I like that plan, and I think that's exactly probably what we would teach too. Be prepared.
So it's interesting. We had a little bit of a ledge effect on the edge of the stent, which again just gives me more support that I think we have to post-dilate this. Okay.
Rob, what's the
back it up just a
balloon
bit.
that the Megatron is mounted on? Do you know the technology on that for us?
It's the coronary platform from Boston Scientific. I don't think I could accurately represent the exact platform, but it's obviously the Boston Scientific coronary platform. Obviously, you all saw that the 6 went right up. There is some recoil still. Interestingly, I'll take a snapshot of that.
Yeah, I was going to say take a 1X. It
All
looks
right.
like there's a lot of plaque there. Wow.
Yeah. But I think
so why don't we take it up again and leave it up for a good 30 seconds. All right. I'll take it up to 12.
And just for the audience, the patient's fully heparinized for this, obviously.
That is absolutely correct.
Mm-hmm.
All right, and we always target for these cases an ACT between 250 and 300.
Although the one good thing here is we already know she's collateralized, so I don't think she's going to thrombose distally. But
which workhorse wire are you using, Rob?
I have a personal preference for the, interestingly enough, a cordis coronary wire, which is called stabilizer. And the reason I like that is it's a very, very short transition. There's a 3 centimeter transition. I know a lot of people like wires like Spartacore, which is an excellent wire, but from Abbott. There's the Grand Slam wire, which is a really good support wire, 014 support wire from Asahi. I think these are all excellent wires. The cordis, I just think in my hand, because of that short transition, it allows us to do relatively complex renal work, relatively complex visceral work, and as I said, I'm pretty fond of it.
What do you use, Tino?
Yep.
Yeah, we use a Grand Slam, but I like the short, the concept of that short transition. So
we're gonna mag up one.
Always learning, always learning.
Oh, looks good.
Looks pretty good to me, right?
You can see the liver woke up too.
You see the hepatic coming up pretty quickly now. It's actually faster than it was before.
Ready?
Yeah. I, for one, am very, very happy here.
Yeah, this is a great result. The only thing I would maybe add, Rob, is it's an aortogram, just to look at the arc and see if there's maybe reversal of flow. I don't know. It's something to think about.
I mean, we could also just go down and wire the IMA right now, but
to what end?
I don't know that it's going to change anything than what we're going to do. And actually, if you really look at this SMA angiogram, you're actually seeing the middle colic fill the splenic flexure antegrade. You see that coming up there in the upper right portion of the film, right? So again, I'm actually thrilled we didn't cover the inferior pancreatic duodenal. We didn't cover the middle colic. Our stent column, really just covered the entire length of the CTO, and obviously it was about a 4 centimeter CTO. And I'm actually very, very happy.
Yeah, it's a great result.
I think this is a great result, Rob, and you didn't have to go to the IMA, which is, I think, a great strategy here. I think I might have gone to the IMA first to try to dilate a little bit and get myself some patent vessel just in case my CTO didn't go as well as it went for you guys. But in retrospect, I think you guys really showed how you can not even touch the IMA. That's your lifeline. Stay in your SMA, get a great result. And I think this is great. I mean, I think he's going to get a lot better.
Yeah, I totally understand the strategy of sort of taking the low-hanging fruit first and then tackling something more challenging. I think for today, to your point, the IMA, that's what she's living off of. We didn't want to touch it. We've got the A team here today. Everyone's working so hard to take care of this patient, and lucky for her, we were able to collaborate together, get the SMA open, and I think she's going to feel just a whole lot better very, very, very quickly.
Great. Rob, before you go off camera,
any last?
I just want to show,
I'm
if you
sorry?
can show your radial setup and how you're working where the arm is really close to you. And I think this is really important.
Yep.
People start to do radial procedures, how to position the
Sure.
arm, how to get going. I think there's a lot here.
So, we have the arm not 100% tucked in. It's probably at a 20-degree angle off the long axis of the patient. We've got a 5/6 slender here in the wrist. This is our MPA MP1 6 French guide. This is our 014 wire setting here. And so, we're all set up almost like it's femoral access. And obviously ergonomically, we're really working like we were working left femoral. And we found over the years it's a much more ergonomic way to work. It allows us to have full access to the patient. Very importantly, we want to have our anesthesia partners to be able to have access to the patient also. And then again, Tino, you and I spoke about this. We really love this flex arm configuration because it really optimizes everybody in the room: the nurses, the technologists, the physicians, the operators, the anesthesiologists, to be able to have unlimited access to the patient. And that's one of the real great benefits of having this room set up this way.
Great job.
Any last closing thoughts? All right. Thank you all so much. Thanks for joining us. And we look forward to seeing everybody next month. So thanks, everybody.
Thanks, guys. Great case. Thanks, Tino.
All right. Bye-bye, guys. Great job.